No, look, I just want to thank you for coming here tonight for another Mental Health Practitioner Network meeting. So I think it's exciting. And we're really privileged tonight to have Dr. Andrew Stone from Whyte here, and I'm not sure where the Woolcock Clinic is, but I'll get him to introduce himself. But we thought with the interest in sleep and sleep disorders, and the number of clients that come to see us with where sleep is a primary concern of an issue, and there's often mix of medications, and we're always trying to do all the psychological stuff and then worry about the sleep. Knowing that we've got some great specialists here in Whyte that can help and guide, or maybe we can talk about that into professional collaboration that we can do, and get more information. But I think if we can all be on a really good page, look at the evidence, and we've asked Andrew to talk a lot about sort of the neuropathology of sleep and some of the disorders and treatments and just what's current at the moment. So, and then hopefully at the end we can have some, sort of some good interactive discussion, if that's all right. So over to you, and thank you so much. Andrew's made his time here, volunteered his time tonight, so I think he's really an honour. I really appreciate that. Thank you.
Yeah, well,
really appreciate you.
Thanks very much for inviting me to speak. And I haven't spoken to this audience, this sort of audience before, so I've tried to think of how to present in a relevant and interesting way. But hopefully, if there's any deficiencies, you'll just pipe up and ask, and maybe we can address what you want to know. So I've tried to do an overview. As up here, I'm at the Riverina Respiratory and Sleep Centre, so I'm a respiratory and sleep physician. I also do monthly sleep clinics at the Woolcock Institute in Glebe in Sydney as well, and that's so that's sleep clinics down there. All right, so I was asked to speak on sleep physiology and also on the pathophysiology of sleep disturbance, and also a bit on therapies that would be relevant to you in your practice and roles. So first to sleep physiology. So I apologise, I'll have to keep referring to my slides because I don't know them so well that I can just speak. But so sleep is a natural behavioural state characterised by a reduction in voluntary motor activity and a decreased response to stimulation. So we all spend roughly a third of our lives in this state. It's easily reversible, it's self-regulating, and conserved through evolution, although the precise functions aren't clear. So there's a number of theories. So what happens during sleep? So there's reduced responsiveness and altered brain electrical waveform activity that we can see on EEG recording during sleep studies. And sleep is divided into distinct stages based on the pattern of brain activity, eye movements, muscle tone, and autonomic response. So a couple of key discoveries on the neural pathways involved with sleep. So in 1930, von Economo described symptoms of pathology in encephalitis lethargica. So there were lesions in the hypothalamus that either caused excessive sleepiness or prolonged insomnia, depending on the location. So posterior seemed to lead to excessive sleepiness and anterior to insomnia. In 1949, Maruzzi and Magoon described the ascending reticular activating system. So this a system of arousal in the brain stem, and stimulation in cats led to an EEG pattern of wakefulness. There are systems, neural systems involved in both arousal and sleep. A bit more extensive for arousal itself. So there's multiple neuronal groups with their own pathways in the pons and midbrain. So there's a dorsal ascending pathway which runs through the thalamus, and a ventral pathway that goes through the hypothalamus and basal forebrain. And the neurotransmitters involved are various, so cholinergic, monoaminergic, so that includes dopamine and noradrenaline, histamine, and there's the hypocretin system as well, or orexin is the other name. And for sleep promotion, there's nuclei in the hypothalamus, and mainly GABA inhibition of the arousal systems. So here we can see just in basic form these pathways. So the red spot is representing the sleep promoting area, and then the green and blue and black are all part of the arousal system, and you can see the different neurotransmitters involved. So histamine here, serotonin, noradrenaline, and acetylcholine. And here again, just a similar sort of diagram, but just showing where agents can act on this system. So, for example, potentiators of the GABA inhibition of arousal, including alcohol and benzodiazepines. And then in green, you've got your H1 and H3 agonists and muscarinic antagonists, for example, acting to promote sleep, and orexin antagonists as well. So I'm just looking at the stages of sleep now. So you've got a division into non-REM and REM sleep. So non-REM is further divided into 3 stages. So stage 1 is a transitional phase. So that's light sleep. You don't tend to stay in that stage for very long. So there's a slowing of the EEG pattern, the waveform, slow rolling eye movements. And then you enter stage 2 sleep, which has its own distinctive EEG characteristics, decreased eye movements, reduced muscle tone, and deceleration of the respiratory and heart rates. And then there's stage 3, or slow wave, or the deepest form of sleep, where breathing is in its most stable pattern, very rhythmic, and there's a decrease in heart rate, and you see these big delta waves on the EEG. Then in REM sleep, very different picture. So you have the rapid eye movements, which give the stage its name, and muscle paralysis, except for the diaphragm and the eye muscles, low muscle tone, very variable breathing pattern, so in stark contrast to stage 3 sleep, and a mixed frequency EEG. And this is the stage of sleep where you're dreaming the most, and so it makes sense that your muscles would be paralyzed during that stage of sleep, so you're not able to act out your dreams. So all the sleep stages are normal, and we usually just cycle through them through the night. So there's multiple cycles during the sleep period, and there's brief awakenings between cycles. And it's important to recognise that those arousals are just a normal part of the night. So it is normal to have brief awakenings, just as long as there's not a lot of them, like we see in some of the conditions that disturb sleep. So you tend to have more non-REM sleep in the first half of the night, and then more REM occurs in the latter part of the night. So that's a normal pattern. So this is just an example of the summary of a normal sleep study. So on here, this is the hypnogram. So this shows the stages of sleep. So in yellow is stage 1. So it tends to be very brief, just when someone first drops off, but you don't stay in stage 1 for long. This green here is stage 2, and then the deeper level here, stage 3, and these are periods of REM sleep in red. So you can see the cycle through. The longest period of REM sleep is in the morning there, and most of your slow wave sleep is in the first half of the night. Perhaps in this case, a few more arousals than you would ordinarily expect, but we can see there's no evidence of sleep apnea here, so this is where respiratory disturbances would be recorded, and there's absolutely nothing there. And the oxygen trace, the oxygen saturation trace, is very even through the night and up close to 100%. And this is just showing the patient's body position through the night. So it's normal just to shift through different positions. And so there are sleep changes that you just expect with increasing age. So total sleep time does tend to reduce, and you get a smaller proportion of REM sleep and a smaller proportion of slow wave sleep as well. So, and in young children, you'll see a lot of those stages of sleep. So this is just indicating the fact that the sleep duration does change over the years. These are recommendations that come from the National Sleep Foundation in America, and so we have lower end and upper end recommended ranges. So you can see for your infants, you're expecting them to sleep a large part of the 24-hour period, and for most of us, we're up here in the recommended 7 to 8 or 9 hours per night.
It's only recommended. It's not prescribed.
So now sleep regulation. So here we're talking about the circadian rhythm or body clock. So this is undeveloped in infants, but becomes established during childhood, and it's generated independently, but it's influenced by external cues. So all living organisms basically have their own circadian clock, and it's inbuilt. So the adult circadian period is around 24.2 hours. So that's interesting that it's not quite the 24 hours, it's slightly longer, but we're constantly being synchronized to 24 hours by external cues. So, and environmental light is the most important of those. There's also melatonin secretion that goes through a cyclical fashion. So you get your peak secretion during the night time, and then just disappears to very low levels during the day. And we can see that on the next slide. So this is just showing the melatonin secretion, and also breaking it down into to older and younger adults. And as you get older, the peak of melatonin secretion does go down. But that has an important entraining role. In keeping our body rhythms regulated.
Just Andrew, that's, you don't mind if I interrupt you?
No.
Just wondering, go back the sex differences. Why? Like young men, young women, there's a significant difference there, isn't there?
Well, I wouldn't have said there's a great deal of difference there. Yes, but I haven't gone into that deeply enough to know how much difference there is between the genders, but that would be interesting. So this is just a simplified diagram of our sleep-wake rhythms and how they're regulated. So with exposure to light being the key factor, so light hits the retina, and then there are signals to the suprachiasmatic nucleus, which is the body's pacemaker, basically the circadian pacemaker. But it also receives other types of input, and so it generates its own endogenous circadian rhythm, but there's also entrainment by these external cues, so in particular the light exposure, but there would be social cues as well, like our need to get up and go to work, so that we're constantly being aligned to the 24-hour rhythm. So in 1982, Borbelli came up with this two-process model of sleep regulation. So it involves both homeostatic regulation and circadian regulation. So we've spoken about circadian, so that's the that inbuilt rhythm we've got with the master clock being the suprachiasmatic nucleus, with the entrainment from external cues. But then there's this sleep-dependent homeostatic regulation. So the longer you go without sleep, the greater the sleep drive. So this sleep propensity increases, and there's a theory that this is related to build-up of adenosine the longer the wakefulness period goes on. So this is a nice diagram just showing that. So these two things both having an influence but happening sort of independently of each other. So the homeostatic sleep propensity, so all this time gone after waking, so the sleep drive is increasing, and if the person sleeps here, then that drive drops off again. But if you don't sleep there, then it will continue to rise up to this point and then drop when sleep finally does come. And here we have the circadian signal, which just has its ongoing peaks and troughs, and that will be regardless of whether you've slept or not. It will just continue. Okay, so now I'll move a bit more to pathology. So I thought I'd first start with disorders that cause more sleepiness, and then we'll go to insomnia later on. So in disorders causing excessive sleepiness, we can sort of break it up into different categories. So is there something affecting the quantity of sleep? So sleep deprivation, and multiple factors can be involved there: family, social, occupational, medical conditions, mental health disorders. Then there's sleep fragmentation, where the actual amount of sleep seems to be all right, but it's being broken. So obstructive sleep apnea is a classical one there, and that's very common too. Periodic limb movement disorders, but also other medical conditions can interfere with the sleep. So, for example, someone with a bladder disorder and a nocturia as a result of that. And then there's faulty circuitry centrally, so within the brain. There's excessive, there's sort of an inbuilt tendency towards sleepiness, and this is the case in narcolepsy or idiopathic hypersomnolence. So narcolepsy involves what's believed to be autoimmune destruction of the hypocretin secreting neurons in the hypothalamus. Idiopathic hypersomnolence, unknown. And so we all know that if you're deprived of sleep, or the sleep's fragmented, then there's a number of adverse effects from that. And here's a list of many various impacts that have been shown. In particular, vigilant attention and response speed. There's been a lot shown on that, and it's quite an easy one to test in the in the research setting as well. The psychomotor vigilance task has been a commonly used one, where there's a stimulus and the person has to respond as soon as they get that stimulus, and you look at the delay and the number of errors made. Yes, but things like manual dexterity, constructive thinking, verbal and visual memory, cognitive speed, verbal fluency, planning, judgment, and also mood regulation. And so there's a close relationship with depression as well, and there's a bidirectional relationship. It's important to know as well that there is a fair bit of inter-individual variability in sensitivity to this. So, some people really seem to suffer a lot more than others will, and it's really unclear why that is, but that's just the way. And people frequently underestimate their deficits as well as a result of their sleep deprivation, which has been shown in a number of studies as well. So that is of relevance when it comes to thinking about, public health and occupational health settings, when people aren't necessarily good judges of when they're safe and when they're not. And the deficits from loss of sleep can also persist for several days after the actual period of sleep loss as well. And then when you look at chronic sleep insufficiency, again, impaired cognitive and physical performance, reduced quality of life, risk of motor vehicle accidents and other accidents. There seems to be a link with cardiovascular morbidity as well, and reduced immune function. And we've probably all had the experience of when you're sleep deprived and then you get a viral illness. It does seem to happen more frequently when you're run down in that way. There have been some studies which have pointed towards increased mortality as a result of chronic sleep insufficiency, but the data aren't consistent across the board. So there's some positive and some negative studies. And there's this concept of actual neuronal fatigue. So there's changes going on at the cellular level in the brain as well. So that's interesting, and to think about, how much is reversible and how much isn't. Like, do you reach a point where you start to do irreversible damage?
Is it reversible?
Well, I think the jury is well. There's some things like the cardiovascular morbidity, I suppose. But the cellular stuff that I mentioned there at the end, I don't think that's really been clarified. I haven't.
Like the not so concentrated work or a bit slower or all that. So if you're constantly up late for years and then decide you better do something about it, you get more alert by going so much later sleep.
Yeah, I mean it's very good question, and something I'd like to know about myself. Sorry, I forgot to turn that off. Yeah, but I haven't seen a definitive answer to that. But yeah, I think it's possible that if you are seeing changes at a cellular level, that that chronic fatigue could lead to some long-term changes. But yeah, something to explore further for sure. So this is just going back to the normal looking sleep study, and I just wanted to compare it with some very abnormal looking ones. So they're patients with severe obstructive sleep apnea. So here, well, we can see the oxygen trace first of all is extremely different. So you're getting this very unstable trace with severe drops, even going below 50% at times, and the frequency of the arousals extremely high. That's because of all these breathing disturbances, so all these obstructive apneas occurring along here, and you can see that the pattern of the sleep is different as well. So the patient isn't spending as long in each phase of sleep, so it's more broken up. They're shifting from one phase to another more, but surprisingly still managing to get a reasonable amount of slow wave sleep and even REM sleep. But the next one is a different story again. So again, you can see that severely deranged oxygen saturation trace. Not quite so many arousals in this case, but still abnormally high, and you can see a very fragmented pattern of sleep, and the person has not got any REM sleep on that night, and just this one period of slow wave sleep. So it's easy to see from that how the person can feel extremely sleepy during the day and unrefreshed after the night.
Is that all tested with that machine that sits on your face in a sleep study room?
Yeah, so that's from an actual polysomnography where they've got EEG leads on the head, so that's telling us when the patient's asleep and awake and what stage of sleep they're in, and then there's respiratory parameters being assessed with the oximetry probe. There's bands around chest and abdomen to measure respiratory effort, a little sensor for airflow through the nose. So we're getting that extra information from there.
Is there any differences in the side effects between, like, basically just going about sleep and having a sleep debt, or having like partial sleep and just not having REM sleep? Is there any differences there, like in the symptoms that are caused? Does that make sense?
So between having a shortest,
like, say if you were someone that slept just 3 to 4 hours a night for a couple of years, you've got a screaming baby, you've got fatigue and different symptoms from that, and then you're this person who's sleeping every night but they're not getting REM sleep, would there be a different sort of symptoms in that?
I don't think you could differentiate that. Yeah, they would have similar symptoms. So if you've got a short duration but you're getting all the stages, is that what you mean? So I think you can feel similarly impaired in both cases. Yeah.
Andrew, if
Yes.
anyone wants to see what they look like when
Why
I
not?
down, I'm happy to pass this around.
Okay.
I've given my information. There's 3 pictures. Do you want to see them?
How do you sleep like that? For it to be replicated in normal sleep, I would not sleep. If you're a light sleeper generally, what would you consider a light sleeper? Having that all attached to you must be very...
Yeah, well, a lot of my patients do, express initial worries about that, but it's rare that we don't get enough sleep that we can't draw firm conclusions from it. So, we're not asking for it to be a perfect night of sleep, but just enough to give us an answer. So very occasionally you might come across someone who has not slept enough to make the study helpful, but yeah, it doesn't happen very often.
You get enough, you get
Yeah, yeah.
And there's two different types of sleep apnea too, aren't there? Is there obstructive and central? Is that?
That's right. Yeah. So. So again, you would see instability of the oxygen saturation trace, but you don't tend to see the great depths of desaturation that you do in obstructive sleep apnea, and it tends to be more regular. So you desaturate to a similar sort of amount, and it's sort of smoother. Often affects non-REM sleep more than REM sleep for central sleep apnea, whereas in obstructive sleep apnea, REM sleep tends to be worst affected, and you can see it here. So that's because of that muscle atonia and the upper airway muscles relaxing to an even greater extent and making that floppy and more vulnerable to collapse. So yeah, you can pick out some differences, but I mean, you can also have quite a lot of arousals associated with central sleep apnea, but yeah, it's often not as straightforward with central sleep apnea. Like a lot of the cases are associated with cardiac failure. That would be a common cause, and in that case, it's controversial as to whether the central sleep apnea is necessarily a pathological, a foe, as it were, something that absolutely needs to be treated. So there's sort of people on both sides of that argument. But use of opiates is another common cause of central sleep apnea. So which is also common in our society. A lot of people on long-term opiate analgesia, and so that can really interfere with the sleep, and it's always something that I'm keen to know about when I'm assessing someone.
So I have a question for you in terms of these sleep studies. Obviously, one option for a sleep study is to go to a facility where you're staying overnight and you get it hooked up and whatever else. But there seems to be this emergence of people out there who have kits, and they'll send you home with the kit, and you'll. Are they any good? Is my question essentially. What is the quality of the data that you're getting from that?
Yeah, some are good, some are not so good, and there's variability in how much data they're collecting. Some of them are very simplified, and so you're not getting nearly so much information. We also organise home-based sleep studies from our rooms, but we've still got the EEG data. Like a lot of the community ones won't have EEG, and they'll operate on the other signals. But I think there's a place for them because there's a huge burden in the community. So we have to be smart about how we use the sleep lab environment. But you have to be selective about who's appropriate for which study. And a problem that often comes up is the person doesn't see a sleep physician and just goes to their chemist, and they might not be the appropriate person to have that sort of study, but that's how they start off. And then you've got to end up doing the laboratory study anyway in that person. So it's a frustrating field in a way because of the lack of regulation in it. So there's so many.
There's people out there who don't have a background in health who are giving out these machines. I mean, it's referral, but the individual doesn't have a health background, and I just find that unusual, I suppose.
Yes, my personal opinion is that they should be seen by a sleep physician, so that you can triage them appropriately on, where you direct them.
Yeah. And a very practical question on that, is that something that's available to people through the public health system, or is that something that's available only through private health, to actually go to a sleep clinic if you just think you've got sleep apnea but you're not presenting with any sort of acutely life-threatening symptoms?
Well, it's public and private. Locally, we've, just where the lab got set up was the private hospital. So that's just how it evolved here. So unfortunately, we don't have a public lab like cities will have, like the big city teaching hospitals will have their public laboratory. That I have found that a challenge, because often that, the cost issue does come up with people.
With children as well. Have to send with the children to sleep again. I don't know if they're doing really well, but pretty much that's what we have to do.
Yeah. So that's there's definitely challenges there, like that. This is a frustrating thing when people are, they see you after they've already had this quite long pathway seeing other people, but it take a while to actually reach a sleep physician, and then you're trying to pick up the pieces afterwards, and so they might have already had their trial on CPAP treatment, not been properly supported through that, and then, form this very negative view of the whole thing, and then they come to you in a angry sort of frame of mind to start off the process. Whereas if you had them from the start, it would have been much easier. You could form the relationship, explain things properly.
Very frustrating from our point of view too, when you're trying to get a client to properly address their sleep issues or get them properly assessed, and they haven't been, and then they've got all that stuff about what a waste of time it is and how uncomfortable the machines are and how it doesn't work anyway.
Yeah, well, the driver's licensing is another prickly issue. There's often that fear from commercial drivers about what's going to happen. So they might sort of hide from the doctor, or if they do see the doctor, they come in a very negative sort of frame of mind. But that's not all, but you can see that. So this is just showing some of an example of impact of sleep loss, where you've got an alert and a sleepy patient doing a driving simulation test, and you can see the lane position, so the amount of deviation, and these C's show crash events. So
It's not good. Esther, you'll stay in the night.
Yeah, better not drive home.
Oh no. Oh, there we go. Yes, so this is also a driving simulation study, and so you've got people with obstructive sleep apnea and controls, and then for each group, normal sleep versus sleep restriction. And so you can see that the obstructive sleep apnea patients with normal sleep are relatively similar to controls who are sleep restricted. But then if you sleep restrict the obstructive sleep apnea patients, then there's additive effect of the impairment. And this is just showing with alcohol in the two groups, so normal sleep versus alcohol. So you can think of the lack or the fragmentation of sleep as being like adding alcohol to the system. And this is from a study which showed the increase in accident rates in people with obstructive sleep apnea versus controls. So they looked at they looked at insurance information to look at the number of accidents in a group of obstructive sleep apnea patients, and then they looked prospectively 3 years on CPAP at the same data, and the rate came down, whereas with the control group stayed similarly lower over both periods. So now disorders of sleep rhythm. So a lot of things in the modern world can contribute to this. So social, educational, occupational influences, travel, especially between different time zones, the use of electronic screens and abnormal light exposure patterns, so people staying up late and doing all kinds of things. There's also a big relationship with depression and other mental health disorders. So here we can see conventional sleep time in the middle, and then different sleep phase disorders. So delayed sleep phase would be the commonest of them, and there's quite a strong relationship with depression with that. But then there's got advanced sleep phase, irregular sleep-wake rhythm. So people with brain injury might sleep like this, very deranged sleep. They get a bit here, then they're awake for a period. So, advanced dementia might look something like that. And then free running type. So this you might see that in someone who's blind, who is not receiving cues that help them to entrain to the 24-hour clock. So because the inbuilt or the endogenous rhythm is slightly more than the 24 hours, the phase just gradually changes over time. So if you were sort of shut up in a cave without any access to the outside world, that's the sort of rhythm you'd have.
So do we change, or do we need more sleep in winter, or does it just seem that way? Because we have less light hours.
Yeah, I haven't heard anything or read anything on that.
Yeah. Because you always feel sort of more alert and awake and for longer when it's summer and got more light hours. And in winter you just feel like slugging up and sleeping longer.
Yeah, well, there might be something in it, but I'm not aware of the data.
Just like whether it was a natural rhythm that we should be doing.
And this gives a simplified approach to how you try and shift sleep phases when there is a disorder. So you've got your target sleep time here, what's classed as normal, and then so for delayed sleep phase disorder, for example, you're using you're using sunlight. So this is sunlight. So you're trying to shift. You're pushing the sleep phase backward using melatonin in the evening, and then light on rising in the morning. So you actually, that what made me think twice there was how late it looked like the light was. But you move that exposure to light earlier, and therefore shift the phase. Although not necessarily easy to do in one hit, it would need to be done in a sort of a gradual fashion. And then it's the reverse for advanced sleep phase disorder, where you've got exposure to bright light later in the day to encourage staying up later, and then melatonin during the day. And then I've just added sleep hygiene there, where you've got to apply the principles of good sleep hygiene as well. So things like avoiding looking at electronic screens at times, which are likely to contribute to these phase disorders.
Andrew, what's your feeling around the covers now, the coloured screens that you can put on electronic devices? Do you think that's changing the bright white light or the blue light from screens to the greens and reds and other lights? Is it making a difference, do you think?
Yeah, I haven't seen any real evidence on it, but if it truly is cutting out the blue wavelength of light, that's the most potent one in affecting the circadian rhythm, then it is likely to help. And I've heard about the sort of amber coloured glasses you can wear as well, which are likely to help there too.
So where does the blue light mostly come from? Which, I mean, is it TV? Is it iPads? Is it?
Well, all. Yeah, I'm not sure about a differential or a difference between them, but I just regard all of those electronic screens as emitting blue light. So now shifting to insomnia. So insomnia is defined by difficulty initiating or maintaining sleep. Occurs despite adequate opportunity and circumstances for sleep, and is associated with impaired daytime function. So someone who is just simply depriving themselves of sleep doesn't necessarily have insomnia because they might not be impaired during the day. So here's just a simplified model of what happens. So looking at acute insomnia on the left-hand side. So classically, there's a stressful event, and then there's heightened sympathetic nervous system activity, and then that leads on to insomnia because the person is too wired to sleep. That will, in most cases, then subside with resolution of the stressful event. But in some cases, there's this maladaptive learning process where you sort of learn this, these negative associations with the bed and sleeping environment, and then the insomnia becomes independent of the initial triggering event. And so then you get this cycle. So you've got your negative associations set up there, and that's driving ongoing sympathetic nervous system activity, and it sort of just goes around in a circle. So the more insomnia the person experiences, then the more negatively they're going to feel about retiring to bed, and they start to see the bedtime as something to be dreaded. Consequences of insomnia include fatigue, poor attention and concentration, dysfunction in social work and educational settings, mood disturbance or irritability, reduced motivation, behavioural problems, daytime sleepiness, although if the person is given an opportunity to sleep, they're usually not able to, and increased errors or accidents. And there's this ongoing worry about sleep, which is it's often a real central theme in insomniacs. They're very focused on their sleep and thinking very negatively about it. So evaluation involves taking a very detailed sleep history. So that's really taking up the most time of the assessment, and you want to know about triggers and the time course and the pattern. Might pick up evidence of a circadian sleep phase disorder, for example, and the sleep environment as well. So, are the circumstances for sleep adequate, or is it too noisy or uncomfortable bed, poorly ventilated room? Screening for specific sleep-related disorders, so sleep apnea, restless leg syndrome, circadian rhythm disorders, mental health disorders. So as mentioned, there's a strong bidirectional relationship between these disorders and insomnia. And medication is important to know about, and also other drugs and substances, and in particular things like caffeine and alcohol. So there's various categories. So sometimes it's just idiopathic, but it can be seen in iron deficiency, for example. So if the person is iron deficient, then the first thing to do is replace their iron. Renal failure as well. It's well recognised in that group. Magnesium. Yeah.
What is that one?
Magnesium.
Yeah.
We get a lot of patients with low magnesium levels, put them on magnesium when they're right.
So physical exam, that's a more minor part, but you might focus on certain things, particularly if something comes up during the history taking that leads you to think about it. So you might think about hypothyroidism, for example, a person's mental status. So do they seem depressed or anxious? Sleep diary can be really helpful. So I often get my patients to do a sleep diary, and this is an example here. So 2 weeks is a typical sort of duration to do it for, and each row is a 24-hour period with the times along the top, and they just shade the boxes for when they think they were asleep, and they also get them to mark when they actually went to bed. So in this case, it's these little vertical lines are representing when the patient went to bed, and then I usually get them to say when they were out of bed as well. So you can see that this person, for example, they're getting some like occasional naps here, for example, and C is standing for coffee or caffeine intake, alcohol. Occasionally, if it's available to you, you might use actigraphy, but it's not a routine part of the assessment, and it more useful if you're thinking about a circadian rhythm disorder to show that pattern of activity, and then sleep study. Yeah, I think they add something, but you can't be overly reliant on them. They're not extremely accurate, but they can help give a guide.
Do they ever prompt someone to then go and seek some medical?
Yeah. I've had quite a few who come to me and said, "Oh, my Fitbit said this," and all right.
And
So
you've got focused blood tests. So what would they be specifically?
So I wouldn't do blood tests necessarily in everyone, but if you're thinking about hypothyroidism, for example, if there's features of restless leg syndrome, then you would want to look at the iron levels, the magnesium, and the renal function. It sort of depends on what comes up from the assessment as to where you'll take it. The central theme or the central type of treatment in insomnia is cognitive and behavioural therapy. So you're seeking to address the source of the stress if you can, and then there's aspects of sleep education, addressing the maladaptive beliefs, which is the more cognitive side of the treatment, and then the behavioural sides, which include the stimulus control therapy or sleep restriction. Then if there is a circadian rhythm problem, then circadian rhythm retiming. So like we saw in that diagram before with the use of light exposure and melatonin. There's even those, I'm not sure whether you've seen them, the glasses. The bright light glasses. But that's a bit more fancy. Usually I'm just recommending the natural light exposure. I haven't actually had any patient that's gone to the glasses, but
we've just bought a bright light, so we can start doing some bright light therapy with
yeah.
a couple of sort of, got quite a few young men who've got some real problems with depression and sleep, and so we thought we'd give it a bit of a try. And
Okay.
they'll be coming in early in the morning doing their 20 minutes of bright light therapy, and might do a bit of a trial on it.
Mm.
4 young men identified.
Okay.
Let you know how we go.
So what have you got then? Is it the retimer or
It's in the cupboard.
okay?
So Martin Elster that works here has done some training in it, and went and bought one
Yeah.
from the States, and
All right.
it's about that big. And so many lumens.
All right.
200 lumens.
So it's not the glasses then,
It's
but
the stand, the lamp.
right.
Mm.
Yeah. Okay.
So they've got to sit next to it or within, so many centimetres from it. They could be doing their other work, like having a coffee while they have
Right.
bright light therapy. So
Yeah.
20
Okay.
minutes. We'll see how that goes.
Yes, and then pharmacological therapy can be an adjunct in selected cases, but it's certainly not the sole thing to go to. So the goals of cognitive and behavioural therapy to realign the expectations about sleep, reduce the anxiety surrounding sleep, to eliminate the maladaptive behaviours and introduce healthy sleep habits, and break the negative associations with the bed and the sleeping environment. And you obviously need to combine it with the other principles of sleep hygiene. So, for example, said exercise. So regular exercise is a positive thing for promoting healthy sleep. But you, by the same token, you don't want to be doing vigorous exercise late in the evening. So that can work against sleep onset. And then avoiding meals too late at night. Electronic screens we've spoken about. And alcohol can worsen the quality of sleep, and caffeine to be avoided after midday. That's what I usually recommend to my patients.
But not the 4 o'clock in the afternoon coffee.
Well, if you don't have insomnia, it's okay. But yeah.
There are a lot of myths about sleep. So many clients come in and they have, short wakenings and go back to sleep reasonably easily. But they say, I had a terrible night's sleep, I woke 3 times. I get up, go to the loo, but they come back to bed and they go to sleep fine, they might get 6 or 7 hours or whatever.
Yeah.
But their belief is it's bad sleep because they've woken.
Yeah, so I think that's where the education really comes in as vital to realign what they should be expecting from sleep. So I remember going to a session at a conference where there was a well-known sleep psychologist speaking, and he got his patients to do a visual representation of what they thought sleep was, just drawing, and so a lot of them would just put it as this unbroken valley of sleep, without so just going into unconsciousness several hours and then up again, and that's the goal. So if that is your goal, then you're always going to be disappointed. Reassurance is important, and to explain that it is normal to lose sleep during a stressful period. So that piece is relevant to someone who is going through a period like that or has been recently. But also in the chronic insomniac, where the stressful period might have been way back, explain that it is normal to have those periods of wakefulness during the night, and not to become too focused on those, and to identify and highlight and address the maladaptive beliefs. And one of those includes, this behaviour of patients with insomnia to try and spend more time in bed so that they are going to get up to that sleep, but that's only going to lead to more dissatisfaction, because the percentage of that time spent in bed that's actually asleep is very low. So that's what we call the sleep efficiency, that time asleep over total time in bed. So you're trying to maximise that sleep efficiency, and if you can do that, then the person's going to feel much more satisfied. So stimulus control therapy involves instructing the patient only to go to bed only when sleepy, and to get out of bed if they're not asleep after 15 to 20 minutes, and they need to keep on repeating that process until they have a rapid onset of sleep. So it is difficult, because it requires a lot of discipline. I sort of tell people that it's like putting yourself through a boot camp of sorts, because you do have to stick at it to have success. It's all too easy to just, especially in the colder weather as well, just to remain under the covers. But it is recommended that you get up, leave the sleeping environment, do something relaxing for a period. Might be that same period, 15 to 20 minutes. Give it a fresh go. But if you're clearly not sleepy, you shouldn't be returning. You should just wait until you're sleepy, then return, give it another try, and then maintain the same wake up time regardless of the sleep duration. So that's important as well, but also hard for the patient to do, because it's so tempting for them to, once they eventually get off to sleep, to sleep for longer. But that is perpetuating the problem. And so what you're trying to do by enforcing this regular rising time is to build up that drive to sleep. So if you've only got 2 hours sleep on that first night, that sleep drive will be higher when it comes around to the next time to sleep. And for the same reason, avoiding daytime napping, so that there is that elevated drive, because you're only going to hurt your chances of sleeping at the normal time, like if you nap during the day. And avoiding bedroom behaviours that impede sleep. So again, electronic screens, use of those. So they really should be in an insomnia population. They should be avoided really within an hour of going to bed, or at least 45 minutes before going to bed, and they should choose something else relaxing to do, like read a book, or doing crosswords, or colouring in, or whatever it is that will relax them. So this approach is particularly good for sleep initiation insomnia, and then the sleep restriction approach is particularly good for sleep maintenance insomnia, and you can take elements of both of them and use them in a single patient. But in this case, you're focusing on restricting the time in bed to match this as closely as possible to the average reported sleep duration from the patient. So aiming to get the sleep efficiency over 85%. And then once it is over that proportion, then if the person's feeling sleep in the evenings, then you can gradually start extending that time in bed, but still maintaining the sleep efficiency in that high range. So just lastly, with pharmacological treatment, so important to recognise that it's an adjunct, and some people they just want that quick fix, and, but it's only short term usually that. So acute insomnia would have a clear role, and the most common scenario where I'm prescribing them is in hospital inpatients. So they're out of their usual environment and they're in a bustling ward, and naturally they're having difficulty sleeping. But I don't use them a lot in practice outside. I really focus more on the behavioural aspects. But they can have a place in combination with those others. But there's really no long-term data, so it's hard to know whether continuing some of these agents, long-term for chronic insomnia, whether it will be beneficial in the long term. The studies sort of go up to, I think, 3 months or so, really. So we don't really know about the longer term use. I think the data isn't there to my knowledge. So whether it's helpful or whether it's harmful, I'm not sure. But it's usually given in over a 3 month period, and I sort of use it in a sleep phase in training way. So you're just sort of enhancing the body's signal to sleep at the right time while the person is also addressing behavioural factors as well and cognitive factors.
What about the shift workers?
It can be of use, and also like the alertness promoting medications in that case as well, like modafinil or armodafinil could be used in that scenario.
What's the brand name for that?
Modavigil for modafinil. I forget for the other one what it's called. Nuvigil, Modavigil, and so Modavigil is modafinil and Nuvigil for armodafinil. I use it chiefly in narcolepsy and idiopathic hypersomnolence, but sometimes I've used it in other scenarios. But the problem with those ones is the expense. So if you're not prescribing it under the PBS, then they're costly. And PBS is really basically confined to narcolepsy. So you've got to demonstrate on a multiple sleep latency test evidence of pathological sleepiness. It's generally people who are better off don't mind the cost to have that. I do privately prescribe dexamphetamine as well, which cost-wise is better, but not suitable for those with any strong psychiatric history. So that's usually one of the things that rules them out of that form of treatment. I've just given a list of the pharmacological classes. So benzodiazepine is the best known, and particularly suited to short-term use when there's difficulty initiating sleep, and when there's an anxiety element as well. But really, if you try to use them long-term, the tolerance will develop, so they won't be as effective. And then the benzodiazepine receptor agonists, which are zolpidem and zopiclone, So they don't seem to have the same anti-anxiety effect as the benzodiazepines, but they are a better choice in something like obstructive sleep apnea than benzodiazepines because they don't have the muscle relaxant effect. With both of these classes, you should be avoiding taking with alcohol, and there's been some bad press, as you would know, with still knocks and people sleepwalking and doing weird things, and that's much more likely to happen if they're also drinking alcohol with it. The dual orexin receptor antagonists, which relatively new, and I haven't had a patient on one of these so far, but that they seem to be more suited to sleep maintenance insomnia, so maintaining the full night, and because they're new, there's limited experience so far. The calcium channel alpha-2 delta ligands, that's your pregabalin and gabapentin. And so, if got someone with coexisting pain issues, then that might be a good choice. Antidepressants, so there are a number, particularly doxepine and amitriptyline, I suppose, historically. You guys would have more experience with these, but you see a lot of patients on all of those types, really. And then the antipsychotics as well. Well, usually they're used when there's another indication, but I have sometimes seen them where the patient just says, "Oh, that's to help my sleep."
There seems to be a lot of people on Seroquel purely for sleep, and that seems to be more of a recent thing, or I didn't notice a few years ago, but there seems to be a lot of people on Seroquel.
But you're not allowed to prescribe them from the government point of view unless they've actually got psychosis or bipolar. So you can't, the psychs and hospitals put them on, and then they come back to GPs. We're supposed to either tell a lie or say, sorry, we just can't keep going. Because they haven't got that. It's not your only sleep sort of thing. So, whereas amitriptyline or Indep is handy for a number of people who can be quite a small dose, and if they've got pain and they've got back pain or something like that, they've got some depression and they're not sleeping, and it covers all of them. And you might only be on about 10 milligrams, which is a small amount, and you can still jump up to 20, and that's still a small amount. And they're saying, oh, that's really helped a lot. Especially, I see a lot of refugees, and they've got a lot of worries and nightmares and things from people back home. And it's helped a lot, even though it's an older-fashioned one, as long as they're not going to take an overdose. Or, it's quite useful.
Yeah, I have had quite a few patients who've given reports of benefit from taking that. Yes, and antihistamines, because the action is long, they can be quite prone to the morning drowsiness and grogginess, and there's also the risk of becoming intolerant with these. So they're usually more for specific situations, like even a one-off or very short use. Melatonin, particularly when circadian phase in training is required. So that's particularly with your phase disorders that we discussed earlier. And the data is strongest in the older adult group. So there was a significant study done in the over 55 group, and I suppose when we saw those graphs, we saw that it does drop off. The secretion does drop off as you get older. So perhaps, that might be behind the speculation that it might have more of a role in that group. And then there's the over-the-counter herbal things where valerian is the best known one, and I think there is some evidence behind that. But it's recommended that to get benefit from that, it needs to be sustained over a few weeks rather than you noticing an instant benefit on night one. So that's just going back to that diagram of the systems and showing where these things are acting. And that's that's all I had. So I hope that wasn't too long for you. I didn't actually time it beforehand, so I didn't.